Good morning, good afternoon, good evening, everyone, depending on where you're joining in from. Welcome to the USAID Health System Strengthening Learning Webinar Series. My name is Absalom Muramira. I'm the Director of Monitoring, Evaluation and Learning for the Rwanda USAID IREME activity implemented by Management Sciences for Health, MSH. It's my pleasure to be your moderator today as we dive into Rwanda's digital health strategy, data-driven decisions for improved health outcomes. We're happy to be with you today. And before we begin, a few quick notes. We are recording this session for those who can join us live. Your questions and comments are invaluable. Please use the chat box to share your thoughts, ask questions, and react to the discussion. We've set aside time at the end for a Q&A session, so don't hesitate to participate. So as we begin, please use the chat box to introduce yourself and where you're joining in from, and we'll be able to know how and where we are receiving feedback from. So for today's webinar, we are embarking on a journey to explore Rwanda's remarkable transformation in digital health. We will uncover how the strategic integration of digital technologies has revolutionized the nation's healthcare system. Rwanda's unwavering commitment to improving health service delivery and achieving high health equity is truly inspiring. We will see how digital solutions are being used to deliver patient-centered care that puts individuals at the heart of the system. We'll also be able to see how we revolutionize regulatory processes, ensuring the safety and efficacy of medicines and vaccines. We'll also learn how to track health financing with precision and maximizing the impact of every dollar. We'll also learn how digital solutions are being used to empower data-driven decision-making and ensuring that policies and programs are based on evidence. So get ready to discover how Rwanda's leadership has championed the integration of digital solutions in the health sector. We will explore key systems like the Rwanda Health Information Exchange, Open Regulatory Information Management System, Intelligent Health Benefit System, and the Rwanda Health Management Information Systems. These are the tools that are shaping the future of healthcare in Rwanda. Without further ado, let's get started. First, allow me to introduce our esteemed speakers for today's webinar. Excuse me. So we will listen from experienced speakers who have experience and are experts in digital health and the overall health system, both locally and at international level. We'll listen from Anna Bodipo Muyamba, who is the Health Office Director, USAID Rwanda. We'll hear from Sherry Haas, Senior Digital Health Systems Advisor, USAID Bureau for Global Health. Then we have Dr. Anita Asimwe, Chief of Party, USAID IREME activity implemented by MSH. We are joined by Silver Mugumya, Acting Chief Digital Officer, Ministry of Health. We have with us Abimana Gwandenzi Eugene, Senior Technical Advisor, USAID MTAPS Program. We also listen from Philae Naberwe, Product Owner, Rwanda Social Security Board. We'll have Dr. Charles Ntare, who's the Technical Advisor at the Health Information Systems Program in Rwanda. We'll hear from Randy Wilson, the Principal Digital Health Advisor at MSH, Dr. Elizabeth Wanyirigira, the Health System Strengthening Specialist at USAID Rwanda, and finally, Anjali Dibna, the Knowledge Management Advisor, Health Systems in USAID's Bureau for Global Health. Thank you all for joining us today. Your insights are invaluable to this conversation. By the end of this webinar, these will be our learning objectives, and we hope that you have a deeper understanding of how Rwanda has designed and built a thriving digital ecosystem to support the widespread adoption of digital health technologies. We also have an understanding of how Rwanda has adopted global best practices in digital health to address its unique challenges, creating a model that can inspire others. To set the stage for our discussion, we'll hear opening remarks from Anna, the USAID Rwanda Health Office Director. Anna, the floor is yours. Thank you.
Government colleagues, USAID colleagues, MSH team, ladies and gentlemen, all protocols observed. Good morning, good afternoon, and good evening. It is my pleasure to be with you here today and to discuss the digitalization efforts of the health sector in Rwanda. The United States, through USAID, has supported Rwanda's pioneering digitalization journey for decades. USAID Rwanda supports digital health interventions to strengthen the health sector, to deliver health services, and empower health workers where it's most needed. In partnership, we contribute to improving access to care for millions of people in Rwanda. During this webinar, you will hear highlights of this collaboration across multiple health system strengthening building blocks. Routine health management information systems, for example, transitions to district health information software, DHIS2, performance-based financing, and integrated human resource information systems. Focusing on client-centered systems, implementation of medical record systems, such as the Open RMRS and Community Health Workers Rapid SMS. Through the supply chain, introduction of logistics management information systems, ELMIS, and digitalization of key business processes for the new Rwanda Food and Drug Authority, RFDA. Health financing as well, deployment of the Mutual Membership Management System, otherwise known as 3MS, and Intelligent Health Benefit Systems, the IHBS, to support community-based health insurance. Thank you to the USAID Office of Health Systems and the Bureau of Global Health for all of our partners' efforts, the Ministry of Health, Rwanda Social Security Board, and Management Sciences for Health for contributing to this important conversation. I look forward to hearing and learning with everyone. Thank you.
Thank you, Anna, for that inspiring introduction. In just a few decades, Rwanda has made incredible strides in digital health, and it's clear that USAID has been a committed partner throughout this journey. We're eager to hear more about this collaboration and how it has strengthened Rwanda's health system across multiple fronts. Our next speaker is Sherry Haas, the Senior Digital Health Systems Advisor at USAID Bureau for Global Health. Sherry will shed light on the USAID Global HSS Learning Agenda, our learning questions for today, and USAID Digital Health Vision. Sherry, please take it away. Thank you.
Thank you very much. Good morning, good afternoon, and good evening, all. Thank you very much for joining us. As mentioned, this is a part of USAID's Health System Strengthening Learning Series, an initiative by the Office of Health Systems to convene HSS practitioners to share, to learn, and to use evidence and to support our collective efforts towards sustainable health system strengthening. The learning series is a piece of the USAID HSS Learning Agenda, which aims to strengthen the global evidence base and programming by updating, generating, synthesizing, and disseminating evidence related to key areas of health system strengthening practice. It's organized around 6 key learning questions, and the evidence used is to inform design and management of health system strengthening strategies, programs, and to support USAID's broader goals for integrated HSS. So on today's webinar, we're going to be focusing around 2 of the learning questions, which are what are the contributions of systems thinking approaches and tools to changes in health system outcomes, and how do systems thinking approaches affect health system outcomes? And what conditions or factors successfully facilitate the institutionalization or implementation at scale of good practices that improve health system outcomes, and why? What lessons can we learn regarding planning or sustainably achieving results at scale? As mentioned, I'm a senior digital health systems advisor within OHS. At USAID, there are several policy documents concerning the support of digital technologies for health system strengthening. We have the digital strategy, which is an overall USAID document, the vision for health system strengthening, which touches on digital health, as well as specifically USAID's digital health vision. And together, these 3 documents help inform responsible use of digital technologies in the health sector. The digital health vision outlines 4 strategic priorities to help ensure that digital investments are made in sustainable ways and deliver lasting value. These priorities include assessing and strengthening country digital health capacity, advancing national digital health strategies and costed implementation plans and aligning towards those, supporting national digital health architectures, and leveraging global goods where appropriate. So I look forward to hearing from our colleagues in Rwanda and learning about the great work that they're doing. Thank you.
Thank you, Sherry, for that insightful overview. From her presentation, it is clear that USAID is committed to not only supporting digital health initiatives, but also learning and sharing best practices globally. Today, we'll be focusing on how systems thinking and integration of digital tools can drive real improvements in health outcomes. We're excited to see how these principles have been applied in Rwanda. Our next speaker is Mr. Silver Mugumya, the Acting Chief Digital Officer at the Ministry of Health. Silver will present on the key Rwandan digital health tools, the One Patient, One Record flagship project, and Rwanda's Health Information Exchange Framework. Silver, the stage is yours. Thank you.
Thank you. Good afternoon and good morning. I'm happy to be here, and also I will be also testifying the work that USAID and Rwanda has been together working for some years, and also we have worked on a strategy, and the strategy makes a sense of what we are doing. Actually, it has been seen that if we are building without a strategy, we could not be here. So that's why we started with having a key pillars for what we will be doing and what we are implementing in terms of digital. And the first pillar is the strengthening of interoperability standards, and also to allow all the implementation of the health systems talking to each other. This has been a very great pillar that we are developing. I will be giving maybe some updates on where we are. And we have also been working together in strengthening the IT infrastructure in health facilities. This includes providing computers, building net, so supporting the health facilities to be able to be connected so that they can be sharing data. We have also worked together on different ways of visualizing and sensitizing data. This is in terms of like creating reports, dashboards for decision making. So we have been together also in digitalizing primary healthcare. So this is a very huge pillar that we are also still having a long journey to go, but at least we managed to digitalize the primary healthcare starting from community health workers. We are happy that currently the implementation of digital tools in a community, it's also led by USAID, and we have also worked together in strengthening the digital health governance, which is also the top tool that is helping to materialize whatever digital tools that we are implementing. We have the digital health governance structure. This digital health governance structure, it helps us to collaborate. We totally understand digital health as an enabler to all the health services. That's why we have all the institutions together, and we have been putting together all of these readers so that we can have the same view. We can have like a standardized mode way of planning, standardized way of implementing. As you can see, we are having a steering committee. This is at the national level where the Minister of ICT and the Minister of Health, they are putting together their institutions, and their leaders sit together bi-weekly and see what do we have to implement. And under this steering committee, we are having a permanent secretary at the Minister of Health. The permanent secretary is where the budget is planned. The budget is he's the chief budget manager. So which means that the digital initiatives, they are really prioritized in terms of budgeting. We are having a chief digital office, which I'm heading, and also we are working with partners. And at the bottom, we are also having the teams, technical teams from different institutions working together for delivering and implementing the digital solution in the health sector. For the next slide, we are having key implementations. So we have managed to do, of course, the key implementations in all of these pillars. In terms of community, we have managed to digitalize all the community health workers. Currently, our community health workers are serving like more than 14 items that they are providing. They can treat some disease like malaria, pneumonia, diarrhea. They can also do child health monitoring. They can do also malnutrition screening, all of those kind, NCD. And they are having currently, they are digitalized, and the system they are using, it's also connected to the national grid so that the ministry can view how many cases of malaria has been treated in the community per day, per week, per month. So we are able to actually we can take the decision quickly. So the same at the health post, we have managed to digitalize the health posts. So we are having different systems at the health post. We are having like eFish. We are also using the Ministry of Health digital tool that we have created. At the health center, as mentioned before, we are using OpenMRS. We are also using Ibuzima. That's also a new digital tool that was implemented recently. And district hospitals, they are also digitalized, provincial, and also referral. What we are trying to do in all cases, we are trying to facilitate the patient to be unique, so that at least when we are at the national level, we should be able to see the patient as one. If I'm Silver, I should be one Silver across all steps that I'm passing through, either public or private. We are having a flagship project. This is One Patient, One Record flagship project. This project actually, it's the project that we started in 2020, and it has come to help to create a single patient record. I think this is going to be a use case for different countries to help. So we are having all the steps where we are synchronizing the patient data, and then at the end of the day, we can give chance to this patient at least to have his medical record. The architecture of this health information exchange that allows the exchange of data. As you can see, we have a centralized resources, which makes us to make things standard, and we have interoperability layer where we leverage to global goods, and we are having also a point of care applications that connect this exchange that allows at least the patient to remain unique across the steps. Thank you very much.
Thank you, Sylvain, for that comprehensive look at Rwanda's digital health toolkit. It is impressive to see the range of tools being used from the national level down to the individual health posts. The One Patient, One Record project is particularly exciting, and it has the potential to truly transform how healthcare is delivered in Rwanda. We look forward to hearing more about its impact. Next, we will go to our presenter, Dr. Anita Asimwe, the Chief of Party for the USAID IREME activity, which is implemented by MSH. Dr. Anita will present on USAID IREME's digital health interventions across the project's 3 result areas, which are health financing, leadership management and governance, and health workforce development. Dr. Anita, please begin your presentation.
Thank you very much. Greetings, our esteemed participants. We thank you so much for making the time. We are greatly honored to be sharing the work we are doing through USAID IREME with you all. USAID IREME is a 5-year health system strengthening project that is funded by the USAID and being implemented by MSH in partnership with 2 Rwandan NGOs and also Holland-based NGO. We are working with the Government of Rwanda and building onto what has been done way before IREME started to continually improve health systems resilience, ensuring optimizing resources, and looking at how can we continue to offer quality services to all Rwandans. The systems that we are working on through this, that we will be focusing on, mainly within the health financing docket, we are looking at how can we continually work towards an increased and sustainable financing for health, not just from public, but also private. And working with the Ministry of Health, we are supporting the health resource tracking tool to be able to track all the resources that are coming in. And also we are through the performance-based financing, looking at how do we continually expand strategic purchasing. We are supporting the performance-based financing system to be upgraded and offer services as required. And then, as my colleague from RSSB will be sharing with us in a moment, we are also supporting the community-based health insurance claims system to be improved. And with that, we are supporting the intelligent health-based benefits systems. And then looking at governance, management, and leadership in health. We are working very closely with leaders across levels within Rwanda, and with a focus at the DHMT level, the district health management teams, we're looking at how can we have the leadership at this level for health strengthened even further. And through the Leadership Management Accelerator Tracker, we are expecting to see improvements in identifying challenges and also being able to put in place strategies that will help improve the challenges that are identified. If you could please move to the next slide. As we get the slides back up, we are also working with the Ministry of Health very closely with Rwandan partners also in looking at how do we further improve the quality of healthcare services being provided across facilities. And here we are looking at accreditation of health services, and an accreditation system is being worked on so that not only do we have external evaluators, but we will also get to a point where there is internal assessment of the hospitals. And this is very crucial because it contributes to the performance-based financing, as the results from the accreditation are based on as PBF is being used. And then still within leadership management and governance for health, we are working very closely with the central level leadership in digital health and looking at how can this be further strengthened so that we increase the standards. Sylvain has taken us through the strategy and what they're working on. And through this, IREME is supporting a partner management system and also the health information exchange. And then moving on to our third main area of focus as IREME, that is supporting the health workforce development. We are working very closely with the Ministry of Health to see how do we continually decrease the barriers to health workforce motivation and retention. And through this, we are supporting the information, health resource information system, and also the workload indicator staffing needs in the WISN, that is a tool that was initiated and advocated for by the WHO. So we are supporting that to see that health workforce that are being produced are distributed where they are most needed. And then finally, working with the regulatory bodies, professional bodies, we are looking at how can continuous professional development also benefit from IT tools. And in there we have the supporting e-learning for CPD to continually work with the Ministry of Health and the regulatory bodies to improve the skill set and also increase retention. I thank you very much for your attention.
Thank you, Dr. Anita. And apologies to our audience. We are talking about digital and we encountered some tech issues. There were some internet issues, so sorry about that. But Anita spoke to the project very well, and she highlighted the critical work of USAID IREME. It is clear that the project is taking a holistic approach to strengthening Rwanda's health system, and digital tools are playing a central role in that effort, from improving financial management to enhancing healthcare workforce allocation. And these interventions are making a real difference in the lives of Rwandans. So dear participants, your insights are incredibly valuable to this conversation. Whether you have a question or a comment or a personal experience to share with us, please don't hesitate to use the chat box. We are all here to learn and grow together. Thank you for that. Now we're going to switch gears and see how what our previous presenters were discussing, how that is being applied and how it is making a difference in service delivery and leading to improved health outcomes. Our next presenter is Mr. Abimana Rwandenzi Eugene, the Senior Technical Advisor for the USAID MTAPS program. Eugene will discuss the Open Regulatory Information Management System, commonly known as Open RIMS, and its impact on the regulatory processes, the digitalization of Rwanda Food and Drugs Authority, which is Rwanda FDA, pharmacovigilance processes, the digitalization of Rwanda FDA regulatory functions, and the overall impact on the Rwanda FDA. Eugene, please take it off.
Thank you very much. Good morning, good afternoon, everyone. Thank you for giving me this opportunity to talk about the digitalization support that is being provided by MTAPS, by USAID through MTAPS. As a journey to digitalize all the systems of healthcare services in Rwanda, not leaving out the regulatory systems, which is Rwanda Food and Drug Authority, MTAPS has provided support through Rwanda FDA on Open RIMS, which is a system that provides pharmacovigilance component to Rwanda FDA and all healthcare services in general. It has got major functions that it operates in, which is the marketing authorization, clinical trials, pharmacovigilance on active surveillance component, also manages the import and export. But here I will mostly talk about the features that are incorporated in this Open RIMS. The Open RIMS is a system that is aligned to WHO Global Benchmarking Tool modules that are provided through WHO requirements. And it also has its standards that are meeting or are based on the international requirements, like the therapeutic and clinical, atomical, non-proprietary, medical dictionaries, and regulatory activities. This Open RIMS is made in such a way that it meets or aligns itself to the requirements of WHO that leads to maturity level 3, which involves the monitoring of safety of medical products, not leaving out medicines and vaccines in particular. It has, as its name goes, Open RIMS. It has open ends for customization or adjustments or any operations that may lead to any features that the institution may need to adjust to depending on the functions of the regulatory body. Not only to mention that, but also it has got that openness of interoperability with other existing systems that are either owned by the regulatory authorities or healthcare institutions. This has led to a number of achievements that institution or Rwanda FDA as a regulatory agency in terms of pharmacovigilance has managed to reach on as a result of this system being put in place. It is whereby the healthcare providers, the participants, including the patients, can spontaneously report adverse drug reactions, and this has been implemented mostly where it showed a big impact during the outbreak of COVID and Ebola in Rwanda and the neighboring countries, where the system was used as a database or as a data capturing tool, which managed to move the institution from the paper-based to a digital way of data collections. The system has got a number of modules, as I mentioned earlier, but the major one that has supported the institution is where they can be used to conduct active surveillance on monitoring new medicines or new molecules that are introduced in the country, including the recent introduced treatment of dolutegravir for HIV patients, which has been monitored or reported through this system. Implementation of pharmacovigilance Open RIMS has improved the data capturing or adverse event reporting on the institution, whereby previously before it had about 120 reports per year, but as of today, the numbers have increased from that to about 800 reports per year. This is a very big achievement for an institution because they can easily conduct result assessment to understand what are the relationship between the agents or the principal active that is being used and the outcome of the results. To make more of the institution more digitalized and more automated, MTAPS has also supported IRIMS, which is an integrated regulatory information management system that is being used to do its regulatory functions or regulatory processes. It has got a number of modules depending on the functionality of the regulatory body or an NMRA, and these include import and export control, product registration, where you can easily go in and apply for your product registration and by the market authorization holders. It has got other also the capabilities to conduct the clinical trials through the system. However, there are some areas of the system that needs to be improved, which are still ongoing in implementation, like laboratory interoperability with existing laboratory modules and other systems that are available at the institution. This integrated regulatory information management system has interoperability with other existing systems that are being used in the whole process of the healthcare. And one of the key areas or the key systems that has been integrated with this is electronic signature, which is generated by Rwanda Information Society Authority, and also it is integrated with Irembo, which is a payment gateway where the applicant can easily generate the invoice and go ahead to pay his invoice without moving away from his destined position. Implementation of this regulatory information management system has led to a great impact in terms of revenues that are collected through the system to the authority, whereby as of today, about 665,000 dossiers or applications have been submitted through the system, and this has led to the generation of income worth about 5 billion and around 600,000 in USD. It has a number of people, including the staff, who are currently engaged and trained to use the system. And as we talk now, they use it on a daily basis. And if you look at the figures that are actively using the system now are more than 200 people, which makes a very big impact to the project. Thank you.
Great work. Thank you so much. Thank you, John. That was an insightful presentation. So from the results, we all witnessed that open RIMS and iRIMS systems are powerful examples of how digital tools can streamline regulatory processes, how they can improve data collection, and how they can ultimately enhance the safety and efficacy of medicines and vaccines in Rwanda. It is exciting to see how the Rwanda FDA is leading the way in this digital transformation journey. Now we'll continue with our next case study presentation. Ms. Philae Naberwe, the product manager at the Rwanda Social Security Board, RSSB, will present on the Intelligent Health Benefit System, the IHBS, or locally known as Kwivuza system. She will cover major challenges faced pre-digitalization, the key achievements so far, and the anticipated value for the Rwanda's healthcare system. Philae, please proceed.
Thank you. Like you said, from Philae here from RSSB, I'm going to be presenting about Kwivuza, which is the digital solution that is supporting RSSBs, CBHI, and Rama scheme in the digitization process. So with Kwivuza, excuse me, the vision for Kwivuza is to harness the power of the technology to create more efficient and accessible healthcare systems. So we have the aim of streamlining our processes and enhancing accessibility and data while reducing fraud. So this has to do with our operations and benefits that are available at primary healthcare facilities, and also secondary and tertiary, like hospitals at district levels, and also referrals. So this is to make sure that all these facilities are empowered to provide services properly to our members in the most efficient way, while making sure that our benefits are being provided properly. Can we go to the next slide? So before the introduction of digital solutions in terms for these schemes and processes, we had been facing a number of challenges, and I'm going to go through some of them. And so this is process we have been going through for the last approximately 3 years to digitize these processes. So one of the number one issues was in terms of visibility. So most of our processes were manual and paper-based. So this means that it was going from one hand to another, and it created a level of no visibility for RSSB, for the facilities, but also for the management to be able to make important decisions. So with visibility, we had with the lack of visibility due to the manual and paper-based processes, there was lack of oversight, and also it led to multiple inefficiencies, and also fraud activities were not able to be detected. And we also have the case of costs expanding as services and benefits expanded because of the nature of the processes. Delays were also some of the one of the biggest challenges that we were dealing with for the facility to provide, to require their payment, and for us to process the payment would take approximately 93 days. So this means that this would be affecting the liquidity of these health facilities and their day-to-day operations. And we also come up with limited data. This means, again, our ability for decision-making, risks management, and also policy making in terms of benefits that were being provided to our members were not the teams do not have insightful information enough to make those decisions in the most efficient manner. It would require quite more work and time to figure those out. And we also talk about standardizations, which has to do with facilities, also the services that are being provided, which is something that we are still working on with our partners. Can we move on to the next one? So yes, since for the last 3 years, we have had, I would say, two major launches. One for the contribution side of Kwivuza, which has to do with how we collect contributions and money for mutual, and also now how we manage benefits for our members. So we have reduced the processing time from 93 days to 23 days. Of course, this is still a work in progress, and we look forward to making sure that these days decreases and facilitate operations better. And we also have cost savings in terms of operations, and also other items that were costing a bit more because of the lack of digitizations. And also in terms of papers, we had lots of paper coming from the different facilities to our branches, to our HQ. So with this digitization process, we have been able to reduce the amount of papers that circulates amongst the users. And we also have now a comprehensive nationwide data collection in terms of all the benefits that are received and provided by RSSB across the country, with a recorded of approximately 20 million patient visits for the last. Officially, we launched actually for the last 10 months with over 100 million prescriptions. Yes. Can we move to the next? Yes, so with our implementation journey, officially we started in December 2022 to pilot with 35 facilities. So this was to ensure how the system would operate. And we officially launched in April 2023, which is where we actually started recording people's benefits. And now we are looking forward to now the introduction of the pharmacy services, digitization. So this is now on the layer of private and public pharmacies that are providing services, so that we can also enhance and make the processes and the payment process and also the service quality more enjoyable for our members, while also the pharmacies are operations are enhanced. And we are also working on the capitation model, which is going to be introduced to primary healthcare facilities. And also this is a model that is going to be supporting pharmacies operations, but also coming from a place of preventative measures instead of treatment only. So we also looking currently working on now expanding the digitization from primary healthcare levels alone, because right now we are working with health centers and health posts only, but now going up to hospitals, digital hospital, referral hospitals. So now the whole journey, the circle will be fully digitized with Kwifuza, so that all the services and all the benefits are provided in the most efficient manner that can be tracked and improved as we go along. So yeah, this is what we have been working on. And with the efforts that are being put in place to support the digitization process for the CBHI and the Rama schemes at RSSB, we expect to reduce healthcare costs instead of in terms of operations, and identify more patterns in terms of diseases, treatments, how we are spending in terms of diseases, but also the kind of drugs, services that are being provided, improving the health benefits packages because of all these enhancements, improving, of course, the system's efficiency as we go along, while supporting data-driven decision-making policies throughout this process for, of course, RSSB and our partners as the schemes keep growing, and ensuring that we, provide more enhanced and increased and improved services for our members. So that's it from the side of RSSB. Thank you.
Thank you, Philae. It was a good and informative presentation. So the IHBS is indeed a game changer for Rwanda's health financing landscape. So by addressing challenges like you highlighted, including inconsistent practices and delays in invoice processing, the IHBS is not only saving money, but improving the overall efficiency and transparency of the healthcare system. The comprehensive data it collects will undoubtedly lead to better decision-making in the future. Our dear participants, it's a lot of content that we are sharing, very informative, good practical case studies, but we are coming closer to our Q&A session. Thank you for those who have already started posting their questions. We are monitoring the chat and we'll make time to respond to them. So for those who haven't, please start formulating your questions. And like I mentioned, we will do our best to address as many as we can. We are up to our final case study, which will be presented by Dr. Charles Nare, the technical advisor at HISP Rwanda. Dr. Charles will discuss the different modules implemented in the Rwanda Health Management Information System, how they have contributed to informed planning and decision-making, and the general digitalization challenges remaining in Rwanda's healthcare system. Dr. Charles, please go ahead.
Good morning, good afternoon, our dear audience. I'm pleased to share with you a story of how Rwanda has transformed routine health management information system using DHIS2. And this journey started way back in 2012. I will start by highlighting what the situation was before DHIS2. Before DHIS2, there was a multitude of reporting tools deployed and installed in different health facilities. We are talking about more than 500 different health facilities. You can imagine each one of them having their own tool, and these tools were not web-based. And most of them, if not all, were supported by different technologies. Now, this, of course, led to a number of challenges. Number one, there was the data collection process was cumbersome because the tools that were being used then were, very lengthy because facilities were required to report on many indicators. Also, the data transmission between two reporting levels, for instance, from the health center to the district hospital, was purely manual. They would load data on flash disks and any other devices and transport them physically. So it translated into time lost and costs. The other issue as a result of that, of course, was limited data. Data was not only hard to access, but also it was of limited quality, given the tools that we're using that had little or no data validation rules to enhance data quality. And also because of the cumbersome reporting and data collection processes, the reporting times, the time taken to receive a monthly report from the reporting site to the central level took about 2 months, and this has an impact on timeliness. So the government was forced to respond around 2012 through adoption and use of DHIS2. DHIS2, for starters, is a free and open source software. It's highly customizable, very flexible, web-based, and scalable. You can actually customize it to different use cases. Now, the process of adoption and customization of DHIS2 was a highly participatory process. It included a lot of stakeholder engagements, not only within the ministry and its departments, but also between the ministry and different partners. So they embarked on different strategies. One was to, first of all, simplify the data collection tools to make sure that there was only minimum number of data elements to report on. And there was also rigorous trainings of users at different levels, trainings not only on data entry, but also usage of data. So, but all this wouldn't have been possible without some few enabling environments, enabling factors. And one of them was a committed and accountable leadership that was intentional to improve health outcomes based on data-driven planning and resource allocation. And this is consistent with the homegrown solution accountability mechanism of Imihigo. So the other enabling factors was in form of the modest infrastructure to facilitate implementation of DHIS2 that was invested in by government. Now, this is a process that took about 2 to 4 years, and along the journey we have started through different evaluation and assessment mechanisms put in place as an M&E framework for DHIS2. There has been a lot of assessments undertaken using different international, standard tools like PRISM and others to assess or to evaluate any challenges, any gaps, so that they fix them, we have observed a few achievements. And these actually are in form of efficiency gains, because data collection process was simplified. The reporting, the turnaround time for reporting has been tremendously improved. And we have a minimum list of indicators in place. In fact, we have an indicator dictionary in place, which keeps being updated based on the need. The other achievements to talk about was visibility of data. There is a comprehensive nationwide data collection, and it's all accessible by a click of a button. We have also seen improvements in data use. The most important recent example, as recent as this year, is when the Ministry of Health solely used data from HMIs to support elaboration of the health sector strategy plan 5, using data from HMIs. In the past, this used not to be the case. So that one is testimony that there are a number of dividends that are accruing as a result of switching to DHIS2. The other thing we can talk about is because the DHIS2 is highly integratable, there are a number of modules that are being implemented, and some of those are the ones that we are seeing in the slide. So this slide, as we wait for the slide to be up, thank you. The slides you see here is talking about different digitization challenges remaining. Earlier, a few minutes ago, we listened to the progress made in Rwanda's digitization journey by Sylvain. Despite what we saw and listened to, there are a number of challenges remaining. One of them is actually lack of alignment between different systems that have to be integrated and interoperable through the health information exchange. We have a situation where we have a number of systems deployed out there, but these systems are not consistent in terms of the technology, and therefore making them speaking to one another is still a problem. The other challenge is about the infrastructure. We still have a number of infrastructure, and we observe this through the monthly, annually compiled report through HMIs, from where we see that some facilities out there still have issues when it comes to infrastructure, internet, and computers that are old or that are lacking. The other is, of course, improving and building digital literacy to enhance and foster the culture of data use and sharing. Thank you so much.
Thank you, Dr. Charles, for that comprehensive overview of the Rwanda HMIS. It is clear that this system is playing a crucial role in collecting and analyzing health data, which is essential for informed decision-making at all levels of the health system. While the challenges remain, Rwanda's commitment to continuous improvement in digital health is evident. This was our last presentation, our last case study. But as we near the end of this webinar, we want to ensure that you have the opportunity to ask any burning questions you may have. We're monitoring the chat, we are collecting your questions, and shortly we'll be requesting our speakers to respond to them. But before we open the floor for Q&A, let's hear a summary of today's insightful discussions from Randy Wilson, who's the Principal Digital Health Advisor at MSH. Randy, the stage is yours.
Thank you all so much for joining us for this webinar today, and to the presenters especially for the great job they did. I think you'll all agree that Rwandan's digitalization journey is a perfect example of how a Ministry of Health and its partners were able to use systems thinking approaches to drive change and to transform service delivery across the country. This included focusing on strengthening not just the service delivery building block, but on looking at health financing, human resources for health, and all the other dimensions of information and data use across multiple sectors. The other, another important building block is governance. And as was presented by Silver, they've got a strong governance structure put in place, guided by continually updated digital health strategic plans going back over a decade. Another important element of this systems thinking approach was really to engage the full spectrum of stakeholders in the process of implementing, designing the systems. And at the heart of it all is keeping the focus on the beneficiaries and patients. During this webinar, we learned how Kwivuza and Open RIMS, for example, improved system efficiency and reduced costs. How the DHIS2 was used to support policymaking in addition to disease surveillance and response, some of the more classic use cases. And how investments in medical record systems and the single patient record flagship project have improved client-centered services and improved continuity of care. Throughout this journey, Rwanda has benefited from and contributed to the development of key global health digital goods, the DHIS2, OpenMRS, IRIS, and OpenHIE and OpenHIM. All were contributed to and are being used within the context of the Rwandan digital health ecosystem. So we thank you very much. I'm going to hand back to Absalom to field the questions for us.
Yeah, thank you, Randy, for that comprehensive recap. Now let's open the floor for questions. I see some hands raised. We have a couple of them already listed in our chat box. And I see quite a number of questions around the one patient, one record. Must be so interesting. So I'll direct these to Sylvain, but quickly I want to summarize them. So the participants want to learn, or they would like you to share how you ensure unique identification of each patient, as this would appear as a critical masterpiece in this effort. Related to that is also that for unique identification, is Rwanda using UUIDs, biometrics, or what kind of identifiers are used to generate IDs? Also related is how has Rwanda ensured portability of client records across health hospitals? Is this already happening, or it's work in progress? So, Sylvain, I think all these are, related to that ambitious project. Over to you. Thank you.
Thank you very much. Those are very good questions, and this is quite a very interesting project, as you are mentioning. So, how do we create actually the unique patient ID? This is very, very critical. So if you need to make patient unique across the country, so you need to have a very clear methodology of creating unique patient ID. So at the national level, we have managed to create a client registry. Client registry is working as a unique patient ID generator. And it is whichever system connected to Rwanda Health Information Exchange, when they receive a new patient, So in order that they identify this patient uniquely across the country, so the system at the health center or the system at the hospital has to call this client registry and provide it passes whichever national documentation ID that a person has. Actually, we are starting from a national identification number for the 16 years and above. And we are also starting from application number or national identification number for the children under 16. And then when this number is passed to client registry, the client registry, based on this number, it creates with its algorithm, it creates a unique patient ID. And this unique patient ID shows the facility where you are, and it shows also the random number that is given to that person. So the client registry was created and is working, and we are currently having more than 155 instances that are using this, and they are connected and are providing also this unique patient ID. So we have a community health worker system that is connected. We are having also a health post system connected. So we have a number of systems that are providing this unique patient ID. How do we ensure the portability of the patient file? So for us, the patient file does not need to move. So what happens if a patient attends a health facility A? So there is a unique patient ID that is provided. Then at the national level, we have a shared health record. A shared health record, it is a registry that is having a unique patient file. And this file, at the end of the episode at the health facility A, there is mainly data, there is a summary of the data that is synchronized to the national level in that shared health record. And that shared health record gets a longitudinal patient file so that helps the next health facility, which is a health facility B, if they need to consult and know what happened to clinic A, so they can just put the unique ID of this patient in their system, and then they quote this shared health record, and then they can see the previous record, and then they can take it from there. So you don't need to move with your record. We are not connecting any system to another system, but we are connecting every system to the HIE, and we are asking every system to provide a unique ID and to synchronize the data at the end of each episode. So that's how we ensure the portability. Is this happening or work in progress? Of course, this is happening, but it is still also a work in progress. We have managed to connect at least like 3 different systems, but you need to understand that we have more than 1,000 clinics in a country. I mean the health facilities, if I count health posts, health centers, and hospitals, and they are all using different systems, different health information systems. So all of these health information systems, they need to connect. So, and when they are connecting gradually, it's when we are getting all of this done. The infrastructure was made, but the change management is still ongoing. Thank you.
Thank you, Sylvain, for the comprehensive explanation about the one patient, one record. And you have really responded to the different questions that I tried to summarize together. We have a person in the audience raising a hand. Agatha Lawson, please, if you can speak to us. If it is a question or it's feedback that you'd like to share with us, please go ahead. I see you on mute. Right. Please go ahead. Agatha, can you hear us? Okay, back on mute. So we still have quite a number of questions. There's a question for Eugene. The question is, how far with the CDSS at facility level, as this can contribute to reducing medical diagnostic and prescription errors, and later improve on clinical outcomes as well, patient waiting time and satisfaction that can be positively impacted. Over to you, Eugene.
Thank you, Absolomon. First of all, I think this question goes to, is not, because the systems that are generated or are supported by MTAPs are not looking at prescribing trend, or neither are they talking about the medical records, but what we do is the capturing of any adverse drug reactions or any unrelated medicine events that are generated by or are experienced by the patients. So for this, I think this question should have gone to somebody on the electronic medical records, because we don't get engaged in the prescribing trends.
All right, thank you, Eugene. Okay, if time allows, Sylvia will come back to that, but we also have some quite interesting questions about the IHBS, and as I've been trying to put them together so that our colleague Philae is able to also give a comprehensive response. They're asking that creating demos or in, okay, so I think this one also goes to MOH, sorry about that. Are there any plans to integrate digital health systems into university curricula, especially for students pursuing health-related courses? And then says creating demos or interactive modules could allow students to access and learn these systems, thus enabling them to seamlessly transition into the health workforce. But first we go with Philae. With Quivuza being implemented, also, I think was asking, is Quivuza being implemented also in public and private pharmacies? Does it mean the out of expenses for medicines for households will be reduced? The other one is that what are actions for pharmacy digitalization? Okay, what actions for pharmacy digitalization will be done? Are they both public and private pharmacies included? I think she briefly talked about that. Is this describing digitization for the entire national schemes or just a couple of mutuals in the scheme? Philae, if you can quickly touch on this.
Yeah, so currently primary health care, so this is health centers and health posts have been digitized. So this means that those are health facilities that are supported by mostly mutual, even though health centers do provide Rama benefits in case you're a Rama holder, a Rama beneficiary. So now I spoke about now the digitization of pharmacies. So this includes all pharmacies. I think it's approximately 200 and above pharmacies. So this would enable the services that they provide to our members would be digitized. So this means that even the payment process will be enhanced and more efficient for these pharmacies to receive their payments on time, at least because it's one of the places where we had delays. So this process would allow us to enhance the process that pharmacies have to go through. So it would cover all the pharmacies and enable them to provide services better.
Thank you, Philae. I have one question for Charles. It says, Charles mentioned interoperability still remains a challenge. Looking at all of these siloed systems, Can you share lessons learned for countries starting with digitization? Over to you, Charles.
Yes, I think if you remember well, my slide and also slides presented by Sylvain talked about interoperability as one among the key pillars that now the ministry is focusing on. It has also come up again in the recent situation analysis as a need to enhance it. The reason why it remains a priority is because it is key even to implement the longitudinal tracking of a patient through unique identifiers, and also to be able to exchange information for better, efficient, and service delivery. Now, the lessons learned in this journey is that it is a resource-intensive undertaking. Because for systems, be it resource, tools like different repositories, or applications at points of service delivery, for them to be interoperable, they need to conform to certain standards, and defining and making sure that this is achieved takes a bit of a while, because the prerequisite in this is that you need, first of all, to ensure that you put in place the requisite infrastructure for digitization, because without digitization, there wouldn't be these tools developed and deployed. So the prerequisite here is ensuring that you put in place the digital IT enablers in terms of infrastructure, and this is a resource undertaking tool, very resource-intensive tool intervention. Therefore, it comes back to financing of the digital health tools that are required. And this may vary from country to country. It may vary from context to context. But I think the most and underlying factor here, at least for the case of Rwanda, is a committed leadership that wants to change now the way business is done, with ultimate objective to improve health outcomes. So how you approach it again, there could be no all one common approach. There could be differences from context and from country to country in terms of how you approach it. But of course, the landscape for this, it requires that you put in place the needed infrastructure for you, first of all, to digitize and deploy systems, and then work on interoperability requirements between those systems through, for the case of Rwanda, the Open HIM. Over.
Thank you, Charles. There's a feedback here. Wow, fantastic work, everyone. Truly impressive. We all aspire to this level of excellence, commitment, and impact. We need absolutely everything documented, how you operationalized governance, and how you designed around patient-centric use cases. Personally, I'd like to understand how you manage the Open HIM interoperability framework, and how the recurrent costs of registry design and management are handled. So I'll pause here and invite Sylvain, if we can quickly respond to this, and maybe talk about how, I saw some questions around how to capacitate students and professionals on digital health, if there are programs for that. And then we'll proceed with the other remaining sessions for this webinar. Over to you, Sylvain.
Thank you very much for these good questions. Of course, having technology is one thing, but the change management takes time, and also it's very, very important. So we have managed to implement different technologies, but we understand that the digital literacy is very important for our healthcare providers. So that's why we have started embedding the digital health literacy in their programs, pre-service programs. I mean, while they are still at universities, while they are still also in their nursing schools. So we are also doing the implementation in the decentralized way. We have distributed different what we call digital ambassadors in the cell, so where they are close to the health centers and health posts, so that they can continuously train these healthcare providers on the digital tools and supporting them and accompanying them so that they can be familiar with these tools. So the program are existing, but I totally agree that we need to strengthen this, and this is going to be also a huge undertaking, because we need all stakeholders to come together and also support to have these far away community health workers sitting at their home, having an issue clicking on a smartphone. Also, they should be having someone closer to them in their family to support them. So these programs, they need to be enlarged, but this is actually on the table of the Minister of ICT and the Minister of Health to have all of these trainings done, all of these healthcare providers capacitated so that they can use these technologies. Over to you. Thank you. Yeah, sure, let's start.
Thank you so much, Sylvain. Unfortunately, we're running short of time. I know that we still have good and burning questions in the chat. We have them, but please feel free to continue engaging with us through our media platforms on LinkedIn, on Twitter and Facebook. We will get in touch with you. So thank you to the speakers for responding to these questions. I know if time allowed, we would have even continued to engage. So in the few minutes left, I would like to invite our next speaker, who's Anjali Dibna, the Knowledge Management Advisor, Health Systems in USAID's Bureau for Global Health. Anjali will discuss the ongoing participation opportunities in the 2024 USAID HSS Learning Series and provide information on how you can submit webinar ideas. Over to you, Anjali. Thank you.
Thank you so much, Absalom. And I want to also echo your thanks to all of the presenters and to the audience for sharing their knowledge and insights with us today. This has been such a rich learning experience, and I've taken so much away from the examples that were shared by everyone and the questions from the audience. Before we close, I wanted to share a few additional items with all of you to continue your learning journey on integrated health system strengthening. As my colleague Sherry mentioned at the beginning of the webinar, today's event is part of the USAID Health System Strengthening Learning Series. Starting in 2024, we've been inviting members of the global HSS community, so all of you, to pitch webinar ideas that advance learning on HSS in a substantial way to be hosted as part of this HSS Learning Series. We've received a number of really excellent proposals for webinars so far, like the one we've all been part of today, and we hope to keep the momentum going. So if you have HSS knowledge that you would like to share as part of this platform, I invite you to please reach out to the email address listed on the slide, hsslearning@usaid.gov, and we'll be in touch with details on how you can submit your idea. And lastly, I am happy to announce our next HSS Learning Series webinar, which will be held on Wednesday, July 24th, on integrating migrants in national health systems. The webinar will feature learning from the USAID Local Health System Sustainability Project, and we will focus on the impact of global migration on health systems. We'll discuss how we can go beyond a humanitarian response to advance the health system's approach to the inclusion of migrants, and how we can strengthen the inclusion of migrants in national health systems when there is an overtly hostile political environment or a negative politically inhibiting environment. It promises to be a very interesting conversation, and I hope to see all of you there. More information on how to register will be coming out soon. And on that note, if you haven't already joined USAID's HSS mailing list, you can do so by emailing the same email address you see on the slide here, the hsslearning@usaid.gov. And now with that, a big thank you again to everyone for participating today, and I'll hand over to my colleague, Dr. Elizabeth, for some final remarks.
Thank you very much, moderator, speakers, panelists, and the participants for your technical insights and engagement. We all agree that digital health offers significant opportunities to improve healthcare service delivery, enhance access to care, and promote public health. However, there are also some limitations to digital health. For example, you've seen internet access, equipment, infrastructure, digital literacy, privacy, and security. Yeah, there are some observations that digital health literacy and digital inclusivity require attention in all steps of the design of digital health solutions. Designing usable and accessible and user-friendly solutions is important. Putting your target audience at the center, following and applying guidelines, testing for usability, effectiveness, efficiency, and satisfaction, and of course, designing accessible and effective solutions for people with low digital health literacy. We believe in a fair and accessible healthcare for all, data-driven decision in the health sector in Rwanda. We all know that the health workers are essential in achieving this, especially people, working in the health sector, all people working in the health sector. Therefore, the United States, through USAID, supports digital health interventions to empower health workers and staff in the sector where it is most needed. We remain dedicated to working in partnership with the Rwandan stakeholders to improve access to care for millions of people in Rwanda. Thank you very much. Be blessed.
All right, thank you. Thank you, everyone. Thank you, Anjali. Thank you, Elizabeth, for your valuable contributions. And thank you to all our speakers and participants for joining us today. We hope you found this webinar informative and engaging. This concludes our webinar. Please have a wonderful day or evening, depending on where you are. Goodbye.
Thank you all. Goodbye.
Bye-bye, Al. Thank you.